Okay, so I think we're good to go. So I am here in front of you. I hope my internet connection does not ditch me like it did last time and everything stays fine. For the record, I mean, people said get a good one. I said, sir, I had Airtel, whatever that fiber one is concerned. So, okay. So I'm just waiting for your comments with the audio and the visual part. Elon Musk, I am so impressed and happy that Elon Musk is attending my session today. Thank you. Hi AG, Dr. Shinad, Yogi, Amit, Purple Cloud. So for today, I have kept pretty straightforward ones, and I hope that the objective is mainly to so there is nothing separate like FMG, NEET, PG. Nowadays, the quality of the paper, if you go through, it's equally difficult for all. It's just the fact that in the FMG exam, negative marking is not there, and in rest of the exams, negative marking is very much present. So I think audio video bata do ji. Thank you so much, Himanshu, Dr. Kamini, Dr. Munib, Dr. Mulai Vendan. Yep, doc. That would be the primary objective. Yes, to sharpen your reflexes. Few days to go. So let's just I thought, why not go ahead with this? Sagar, the questions are pretty straightforward. You can try and attempt them. Okay, we are not getting into any controversies from Supreme Court at the moment. And we are not talking about USMLE. Okay, so okay, I think the screen is clear. Yes, medical research on Mars, that would be great, right? But we need to learn how to generate oxygen there. Okay, hi Ibiza, Abhinav. So let's focus on the questions for today, and they're pretty straightforward ones. Yes, Dr. Yogi, you can attend this and we can start. Okay, yes, Dr. Mulai, I'll try to keep it restricted to English only, a few occasional Hindi words there. Okay, so we have this 20-year-old guy, he has jaundice for past 2 days and he says that he had shifted hostel and he had to carry heavy bags. So, I mean, in college life, no, we tend to, lots of times shift our rooms and we might get tired also. But this guy is having a very, I would say, strange complaint that he tells you that he's having jaundice, and this jaundice is occurring after some kind of a strenuous activity. Hi, Harshnil. Hydroxycobalamin has given answer as C. Ibiza says B. I mean, read it carefully. The history also says that this guy had a similar kind of a problem after trip to Katra. Katra is a place close to Jammu, and people go on pilgrimage. If you have been there, I mean, you can imagine the wonderful place that I'm talking about. Now, my point is the problem of this guy is development of jaundice, and he's having this episodes of jaundice, especially after physical exertion. So I'm still waiting for answers from you guys. I mean, what you think would be the most probable answer for this one? A lot of people are saying workup for glycogen storage disorder. So I think that majority of chaps, I think you are mistaking this to be a multiple choice question from maybe the FMG exam where they have asked about Mcardle syndrome. In Mcardle syndrome, you very well know that the enzyme that would be affected would be muscle phosphorylase. And in this particular case, with respect to the FMG exam, what they asked was a burgundy color urine in a patient. And this burgundy color urine was being produced after strenuous exercise. So my point is that in Mcardle syndrome, what happens is there is no jaundice. Rather, what happens in these patients is development of myoglobinuria. Myoglobin is going to be relatively reddish in color. So this person would be complaining of presence of red urine per se, especially after strenuous exercise. But if you read this MCQ, there is no presentation of kidney involvement. There is no red urine, rather he is having jaundice. So if you're talking about Mcardle syndrome, then from the previous years, I mean, I understand that there has been a question with respect to this particular fact that a chap, he was doing strenuous exercise and then there's going to be a development of a reddish color urine, but this question does not say that. So A obviously cannot be the answer. As far as B is concerned, if you're saying hemolytic anemia, guys, hemolytic anemia should be having an elevated LDH, because LDH, one of the components of LDH is, or one of the subtypes of LDH is present inside RBCs also. No? In this particular case, LDH is given to be normal in the question. Anyway, if it was hemolytic anemia, do you think that the hemoglobin is going to be 15? Absolutely not. So I'm still waiting for diagnosis from you guys, which surprisingly hasn't come, considering the fact that all of you are brilliant chaps and you've all read this disease so many times in your career. One of the commonest liver diseases that you'll get in your clinical practice is going to be Gilbert syndrome. And Gilbert is going to be characterized by elevation of serum bilirubin, especially after any kind of physical stress in a patient. I mean, there could be reasons, some people with Gilbert, they might actually develop jaundice, especially after intake of medicines. Like if it's a female patient, maybe with usage of OCPs, she might end up with development of jaundice. But in this particular case, there was physical activity, I mean, excessive physical activity. I mean, the question said, this guy has to change a hostel and he has to carry heavy bags, and then he went to, Katra, Jammu for pilgrimage, and that is when he had this problem. So first of all, when you read this MCQ, because this is related to the liver, so your thought process should definitely be that this chap is not having any hemolytic anemia, because if it was hemolytic anemia, then I mean lot of parameters, especially hemoglobin, would be less, LDH would be elevated, and yes, Himanshu, you're right, Gilbert would be related to a decreased activity of UDP gluconyl transferase. So in this particular case, I mean, A and B cannot be the answer because of the reasons I explained. For those of you joining in, I'll just say that again. Glycogen storage disorder, the issue is going to be rather a Burgundy urine after exercise. Hemolytic anemia, you should have a low hemoglobin, elevated LDH. Yes, fasting could be another trigger that can trigger this. Yes, especially after Ramadan, we get a lot of patients with jaundice. That could be Gilbert syndrome. N-acetylcysteine with forced diuresis, we very well know. One, N-acetylcysteine is used for paracetamol toxicity. But N-acetylcysteine with forced diuresis, this could also be used for a person who's having, let me say, acute tubular necrosis. And this acute tubular necrosis could be mainly with respect to contrast-induced nephropathy. I mean, if you are talking about, let me say, a diabetic patient, and this guy undergoes a contrast study without KFT being checked, and there can be instances, no, like you are having a camp in your hospital, and you might be in a rush, and therefore you did not check out KFT of somebody, and the guy with a deranged KFT undergoes a contrast study in your hospital, like an angiography. Now, if you do angiography in somebody who's having a deranged kidney function test, he could end up with contrast-induced nephropathy. So, contrast-induced nephropathy, maybe we use N-acetylcysteine. N-acetylcysteine is used two times. One, you very well know, paracetamol toxicity. This is not a case of paracetamol toxicity. Second time, you're going to read about this with respect to N-acetylcysteine being used for contrast-induced nephropathy. And yes, Akash, you have a good input there. That could be cold hemolysis. In fact, a lot of you might be thinking in terms of March hemoglobinuria. You get that in soldiers, that if we will do physical activity, there could be hemolysis occurring, March hemoglobinuria. The point is, every time there's a hemolytic episode, the hemoglobin of a patient cannot be 15 and the LDH of the patient would not be normal. So, I mean, if you focus on the workup of this patient, this particular segment that I've highlighted upon, it's not possible for a chap to be having a hemolytic anemia, which leads us to the final answer to this question, which I'll just mark, though I've already explained that. I mean, every time you get a patient, I mean, because this is the commonest congenital hyperbilirubinemia, a chap comes to you and he's having jaundice, and then he ends up with jaundice, especially after physical activity, after fasting, due to religious reasons, or for that matter of fact, taking of OCPs in a female, you have to diagnose this particular condition. And in fact, it's been discussed pretty often. You just had to pick up the clinical cues in this one. So we are sorted for the first one for today. I think a good opening by a lot of you. Let's move on to the second one for today, which is related to CNS. And we have this 70-year-old man who presents to the emergency room. And well, this old man, his wife is giving history. I mean, he is not in a position to, sir, ECG questions were yesterday. So today we don't have ECG based questions. And there's a separate video on the ECG component, which you can go through it. So I thought, let's focus on those where ECG is not present today, because people get, bogged down by that. Okay. So we have this patient, yes, after 21st it will be FMG sessions. Today also, it's a combination of both of them. So it depends on you whether you want, you have it in you to handle all this. Okay, okay. We have this person who says that her husband is having difficulty in forming sentences, gait in unsteady with difficulty in drinking water, and I'm getting varied answers. I am getting a A and a B and a C. Well, when it comes to middle cerebral artery in a patient, the clinical manifestation of MCA involvement will mainly be in the form of aphasia. And along with this aphasia, you would also be having is a contralateral arm weakness. If you read the question carefully, there is no contralateral arm weakness or a contralateral leg weakness described in the patient. Rather, he is mentioning gait is unsteady. You know, the person is having abnormality. So I don't think so. The answer should be given as middle cerebral artery per se, because first of all, you should be very clear because the symptoms of this patient are improving within 10 minutes. This is a transient ischemic attack. And the most important keyword of this MCQ would be ECG is already discussed, doctor. There's a separate video on my channel for ECG. You can go through that. It describes all the ECG that you want to understand. Tavish, we'll take care of that. The key word of this MCQ is difficulty in drinking water, that is dysphagia. Now please tell me, if somebody is having difficulty in drinking water, I hope everybody understands that if there's a dysphagia present, would that not mean brainstem is involved? Yes or a no, guys? I would like a comment in the chat box quickly here. If a question is mentioning regarding that somebody is having all these neurological symptoms like difficulty in forming sentences, gait in unsteady, and then difficulty in drinking water, the moment you're going to read about dysphagia, would it not tell you that the cranial nerves are involved, and where do cranial nerves originate from? They originate from the brainstem. And when you read about the brainstem component, can I have a yes or a no, guys? I mean, if you have a dysphagia occurring in a person, difficulty in forming sentences, gait was unsteady, then it is definitely a transient ischemic attack. But then I understand that all of you are understanding that this is brainstem involvement. And which blood vessel out of these would be involving the brainstem? Can I have a better answer now? I mean, I understand in stroke, you know, you usually read about middle cerebral artery and you read about lenticulostriate artery, but the bottom line is in this MCQ, the moment you read this word dysphagia, I mean, there are keywords in MCQs, no? Whether it be anatomy, whether it be biochemistry, whether it be physiology, there's gonna be a standard keyword that you need to identify. I mean, this particular chap is having a brainstem involvement. If there is a brainstem involvement in this person, I cannot say MCA because MCA does not supply the brainstem. So I think everybody is very clear about this. The correct answer for this one would be the vertebral artery. And why not C? Because middle cerebral artery का branch है तो lenticulostriate artery होता है. I mean, the MCQ began by saying difficulty in forming sentences. So you immediately thought, okay, it is a MCA involvement, but the question did not say aphasia. I mean, the most patients with MCA involvement would be having global aphasia. He's not going to understand anything and he's not going to be saying anything as well. Another thing is gait is unsteady. Gait is unsteady again tells you that probably, you know, a blood vessel, which is a branch of the vertebral artery getting involved. You very well know one of the branches of the vertebral artery, no, pica. If pica is involved, then the cerebellum is also hampered, and once the cerebellum is hampered, then in these patients you could be having this manifestations. So, and every time you read a stroke question, no, don't straight away think in terms of the fact, yes, cerebellum involvement could be due to the pica getting involved. No? The bottom line for this MCQ is, I mean, when you read about the patient who's having a transient ischemic attack, since the history of the patient is in that sense that the neurological symptoms are improving within approximately 10 minutes or so. So the main point I wanted to understand for this particular question is that if he's going to talk about dysphagia, brainstem involvement, your answer should be given as vertebral artery. For MCA, I mean, this is a standard statement, and why it is not ACA, because ACA would be having all those things, no? They would be abulia, then he's going to act weird, no? Personality changes, he's going to be swearing abuses at you, and then there's going to be urine incontinence, there's going to be stool incontinence in the patient. So when you are going to read about especially ACA involvement, the manifestations are very characteristic, and it's just that you need to get used to it so that you get, and stroke questions are, I would say personally speaking, very easy, very simple to straightforward to remember. I mean, all you need to remember is ACA, MCA and vertebral artery. ACL leg weakness would be there. MCH would be contralateral arm and leg weakness, which is not given in this question. Global aphasia is not given. Vertebral, well, understandable. Brainstem involvement manifestations would be given. So we are sorted for the second one for today. Let's move on to the next one. And let's look at how you are able to handle this one. Okay. Yep, Karthik, you were right. You were right. So let's move on to the next one. This is the overlap between surgery and medicine. We have this woman with severe right upper quadrant pain with vomiting. So I mean, every time you read about a woman in her 40s and she's having this right upper quadrant pain, you are obviously thinking in terms of a gallbladder pathology. And the question has the examiner has himself in this question told you that the gallbladder of the patient is involved, because when you did an ultrasound, what happened was that there was a polyp present in this patient. So we just need to figure out what's really going on. I mean, this is the gallbladder of the patient, this is the cystic duct, right? And I can just draw the Hartmann pouch here as well. This is the gallbladder. Okay, give me a sec while I'm waiting for your answers. Yes guys, quickly comments here. This is the Hartmann pouch, and then is going to be the common bile duct. Then this is going to be united by the common hepatic, and we have a common bile duct being formed. And what's happening in this patient is that there is a gallbladder polyp. Now what this gallbladder polyp can do is, sometimes this gallbladder polyp, no, I'll draw it with a different color. What can happen is that this gallbladder polyp, this could actually go and get stuck in the Hartmann pouch. What is happening here is, I mean, why is a gallbladder polyp causing symptoms? The reason why, I mean, normally it is stones that cause a problem, but the point is, in this particular case, why there are symptoms present is because there could be a gallbladder polyp, and this polyp is now stuck in the Hartmann pouch. So the gallbladder will try to contract with force because the Hartmann pouch is obstructed, and when the gallbladder will contract with force, it's going to contribute to biliary colic in this patient because bile cannot be expressed out. So in this particular case, point number one, we obviously need to manage with painkillers. We can give tramadol, we have to give antibiotics as well, we have to give antiemetics. But the bottom line is that if somebody is having a gallbladder polyp of this particular size, then you very well know that gallbladder. Yes, Rizwana, Mcardle syndrome was actually asked, I think not in NEET, Mcardle was asked in FMG exam. But my point for this particular question is simple, that if a polyp is more than 1 centimeter, it could anyway turn malignant, and this is causing issues. No, if it's going to be stuck here like this, even if you let it go today, even if you tell the patient, okay, no problems, and you can go back home tomorrow again, I mean, even if it falls back to its normal position, even if this polyp falls back to its normal position, even tomorrow it can come back and can cause a problem. So we anyway need to plan a cholecystectomy in this particular case. I got a D as an answer, schedule a ERCP guided biopsy. So ERCP cannot reach up to this area, sir. We cannot reach up to this area. I mean, ERCP can go up to common bile duct and you can remove a stone from the common bile duct. No, this is the limitation. I mean, ERCP can come up to here, the common bile duct. This is the area where the ERCP, but to guide it like this, won't be possible, sir, won't be possible. So definitely not on, definitely not on. I mean, we are not going to go in for a biopsy in this particular case. Dr. Debajyoti, my point is, this is not Mcardle syndrome, but it can contribute to Mcardle in a sense that anything, you necessarily may not have a stone in the Hartmann pouch. You could be having a polyp in the Hartmann pouch as well. It's still going to cause biliary colic in the patient. So we are going to straight away go ahead with a cholecystectomy in this particular case. Option A is medical management, but this patient, the question says, what would be your advice? So I'm going to tell this chap that I would definitely like to manage you in emergency with painkillers, antibiotics and antiemetics, but then subsequently it's a cholecystectomy which would be required for this particular case. And for those who are saying that you have to manage, I mean, you have to manage with respect to the fact that only when the polyps will increase in size, or when there's going to be a definitive increase in the size of the polyp, then the bottom line is that if the polyp size is in the range of about 1 centimeter or more, then I'll just fix a small issue. And if the polyp size is in excess of 1 centimeter, it definitely can have a malignant potential. So please read up your surgery component very well, guys. I mean, I think surgery is about, medicine is obviously important, but then surgery is make or break. And this I just put up as a question just to test how well have you studied your gallbladder, because traditionally when anybody is starting surgery after esophagus and stomach, people tend to read hepatobiliary. So if you got it correct, great. But if you messed up on this one, then my suggestion to you would be that do have a look at the hepatobiliary topic once again. Especially gallbladder polyp is something that they love to ask, and this gallbladder polyp in this particular case, I mean, how is it causing symptoms is that if it's very close to the Hartmann pouch, it can cause physical obstruction as well. So we are sorted with this question. The answer to this one will be beta. As far as the solved paper of any set is concerned, that would be uploaded on the app by tomorrow evening. I mean, we have already solved it. It's just that it's going through the final stages of production, and then this would be on the app. Okay, that's for those people who are, especially focusing on that particular exam. Otherwise, let's have a look at a very simple, straightforward question for today, which talks about zinc toxicity. And let me wait for your answers. And I'm gonna give you proxy 30 seconds for this one, guys. I mean, piece of cake. Let's have a look at who answers this first. Yes, guys, waiting. Yep, you can sit back, enjoy, and have a coffee or maybe have your dinner and simultaneously handle the questions that I am putting out before you. I would rate these as easy ones. I mean, one of the easier ones that are normally put up. That's just as to boost up your confidence, because one's confidence does takes a hit as the exam tends to get closer, and we all have that self-doubt coming up that are we really good enough? But believe me, all of you are brilliant chaps. All of you would do great when it comes to the actual exam. So let's see how your brain has kicked in. I got varied answers. My phone had actually switched off. I got it back in action once again. The answer is definitely not A, because I did not ask about deficiency. This is about the toxicity component. So obviously option number A is off the radar. Guys, option A, B, C, they're all manifestations of zinc deficiency. Zinc toxicity results in development of zinc. Zinc is an immunobooster, no? Zinc is an immunobooster. If you have a zinc deficiency, then it causes relatively a lesser immunity. I mean, we were using zinc in also COVID-19. Right, we anyway use zinc in diarrhea, no? We use zinc in diarrhea, but we were using zinc in COVID-19 also because it's an immunobooster. So zinc deficiency results in immune dysfunction and gonadal atrophy. The correct answer for this one is delta, that is pulmonary fibrosis. It's a one-liner MCQ. I think all of you have read this topic so many times. I mean, micronutrients are something that there are 13 on the YouTube channel. You just search for each one of them by number and you'll be able to get them. Sir, paper तो ऐसे ही होता है, mixed bag होता है. Some questions are very simple like these ones where people make silly mistakes, and some of them are really difficult. About in every exam 30-40 questions are gonna be really difficult, which nobody or most of the people are not able to solve. So don't bother about them, but for the remaining ones you need to get all of them correct. As far as this particular question is concerned, guys, my only request to you guys is pretty simple, straightforward. Read the questions very carefully. Immune dysfunction, those of you, I got a B as a prominent answer. You need to understand that I mean, immunity per se is directly related to zinc levels. Lower zinc levels result in immune dysfunction. Answer to this one is D. I mean, you just can't afford to go wrong on this one. Okay. Let's move on to the next one. Yeah, zinc is used in COVID, sir. Zinc is used, not COVID. Mr. Weirdo, this question is something which I think FMG exam वाला question है. ये तो easily solve हो जाना चाहिए, है ना? हाँ जी, zinc को therapeutically use करते हैं सर. पढ़ना, किताब पढ़ो, notes पढ़ो. Zinc कहाँ का therapeutically use करते हैं? आप even if you're listening to songs on FM radio, no, nowadays nobody uses songs on listens on FM radio, etc. I mean, nowadays it's more of YouTube, right? But the basic point is कि हाँ जी super session होगा सर, होगा. The bottom line is कि वो zinc की गोली पे हमेशा ad आती है ना कि डायरिया में बच्चे को zinc की गोली दीजिए, तो acute gastroenteritis में And any patient who's having, I mean, even in COVID-19 initially, I mean, though I'm writing it at the moment, current protocol says in COVID-19 thing is required as far as the current Omicron strain is concerned. BA.4 really does not require anything. Okay, let's move on to the next one. Easy तो नहीं है यार, मुझे तो easy नहीं लगा, मुझे तो कोई पेपर easy नहीं लगता. In my entire lifetime I've never said any paper is easy. All papers are difficult, but it's a mixed bag. Some will be easy, some will be difficult. You need to learn to pick them out, right? I mean, the ones that you never read about, they are the ones which are to be left. Okay, let's move on to the next question for today. We have this 55-year-old chap, fatigability and jaundice again, and his liver shows, ultrasound shows a nodular liver, increased diameter of the portal vein, and the question says what would be the leading complication of this patient. So I am waiting for your answers. Ibiza was the first one to answer. Bombay, that is hepatorenal syndrome for this one. I'm still waiting for other people to comment here. Come on, man, come on, this is pretty a straightforward one. You have a chap who's having a jaundice, there's a nodular liver which tells you that there is cirrhosis of the liver, and at the same time there's a dilated caliber of the portal vein, so that tells you that this chap is also having portal hypertension. The question is simply asking you what is the leading complication that would be occurring in a chap with portal hypertension. Amit says differentiation between GBS transverse myelitis. Amit, that's discussed. No, I mean the bladder and bowel involvement is very characteristic for transverse myelitis and it's not present in GBS. So I think it's discussed in one of the previous sessions. Okay, the question simply says portal hypertension. If you are having portal hypertension, what's the common manifestation? The commonest manifestation of portal hypertension would be one, ascites, and second would be a bleeding esophageal varices. I mean, this इससे easy क्या पूछूं यार आज? I mean, ये आपसे ये पूछा portal hypertension में क्या होता है? Portal hypertension results in what? It results in development of ascites in a patient. The answer to this question is option number delta. As far as the remaining features are concerned, I mean, hepatic and hepatorenal, yes, we get them, but they are all features of decompensated cirrhosis and they take time to develop in a person. I mean, initially, like if you have listened to anybody talking about portal hypertension, you are gonna read about first there is a ascites developing, and then there are collaterals which would be in the esophagus that they're gonna rupture. So we read about bleeding esophageal varices, and then you start having all those complications like spontaneous bacterial peritonitis, and there could be a hepatic enceph. तो ज़्यादा हाई-फाई नहीं सोचना है यार, simple straightforward questions होते हैं. I mean, overthinking कर रहे हो. You know, when you're solving a question like this, what you're doing is you are doing overthinking, and that can result in error of judgment. I mean, इससे easy क्या पूछूं यार कि what is the leading complication of portal hypertension? अब उसमें भी आप branding करोगे कि ये जी ये FMG वाला है और ये PGME वाला क्वेश्चन है, तो क्वेश्चन ही है यार, मतलब ये तो सिंपल ही करना है ना? हाँ जी. Tavish, that's the basic objective of this discussion, to sharpen your reflexes, exclusion capability. और मोस्ट लोग क्या करते हैं, वो सिर्फ थ्योरी को वो एक लाइन को रटते हैं जैसे वो वन लाइनर क्वेश्चन आएंगे, ऐसा नहीं होता. सो तावेश, यू आर राइट ऑन द राइट ट्रैक, एंड आई एम वेरी श्योर यू गोना डू सॉल्व दिस क्वेश्चन वेरी वेरी इजीली. तो जब भी सवाल आए, कॉमन चीजें सोचनी है, रेयर चीजों के पीछे नहीं भागना है, रेयर डायग्नोसिस नहीं करना है. इट्स जस्ट सिंपल स्ट्रेट फॉरवर्ड फैक्ट्स व्हिच यू नीड टू थिंक. द क्वेश्चन सेट बाय पोर्टल हाइपरटेंशन वाले को मैनेज कैसे करोगे. सो यू गोना गो इन विद द ascites एस्पेक्ट हियर. ग्रेट. So I had very good answers. A lot of people have answered delta. Let's move on to the next one. We have this 30-year-old chap with cellulitis who started on antibiotics, and on the 5th day develops a diarrhea with abdominal pain without rebound tenderness. So there's no gut, there's no gut perforation, but there's a diarrhea with abdominal pain. So I think all of you are understanding that this would be pseudomembranous colitis. Dr. Ayantika, all you need to do is from the custom modules, try to do proxy 200 to 300 questions per day, and you would be easily able to handle the exam stress rather than doing GTs, because one, GTs are relatively difficult, and second, performance anxiety would come in. I mean, you would always be wondering how much rank would you get, how many marks would you get, and that pressure comes in, performance anxiety. So I think like every day morning when you get up, like go ahead, select topics from custom modules, especially that you're not good at. If I'm not good at pharma, I'm not good at anatomy, if I'm not good at parasitology and micro, I'll select those topics and I'll try to, create a test for myself and test myself on those. And whatever those I get wrong, I'll analyze them. Hi Utkarsh, Hi Utkarsh, thank you so much. Thanks for all the love that you've given. And yep, you have a psychiatrist among us, among in this discussion, and he can definitely do career counseling for you guys. So Utkarsh, uh, I mean, be kind to these junior people who are present in this discussion. And in case they ping you, do help them out with their career related queries. At what rank would psychiatry be available? Thanks for your kind wishes. Okay, guys, so the diagnosis of this guy is pseudomembranous colitis. Don't be worried, sir. It's never too late. Celiac disease. Celiac disease is present in children, no. If you are thinking about A, celiac sprue, option number A, celiac sprue is gonna be a pediatric presentation. It's gonna be a child who's gonna be having issues. Here he was a healthy person, 30-year-old chap. यार उसको cellulitis था. You gave antibiotics, उसको diarrhea हो गया. So there would be pseudomembranous colitis because when you give antibiotics, there would be an imbalance between the good bacteria and the bad bacteria in the gut. So he is talking about simple pseudomembranous colitis. And if there's a pseudomembranous colitis, then for diagnosis of this condition, we do two tests. One is a stool EIA. I mean, I'll write it, and I've written this multiple times. The test that you do for pseudomembranous colitis is stool EIA. That is enzyme immunoassay for glutamate dehydrogenase. That is one of them. Another one that you will be doing for these patients can be a stool ELISA for the toxins which are produced, that is toxin A and toxin B. Now, if I had written toxin A and toxin B, this MCQ would have been very easy for you guys. So you would have been able to solve it anyway. And another test for this condition is obviously a PCR of the stool, and you can identify this organism. So you can go in for a stool PCR as well. The question is simply on pseudomembranous colitis. Every time you give antibiotics to somebody on a long-term basis, he can end up with development of this kind of a presentation. यार इतने patient होते बोलते हैं ना सर डायरिया हो गया, लूज मोशन हो गया antibiotics खाने के बाद में. That's because of the imbalance between the good and the bad bacteria. So if you want to be sure about your diagnosis, you want to go in for option number B. And for C or stool for occult blood. तो उसको तो डायरिया हो रहा है ना. I did not say dysentery है. I did not talk about any patient of colitis per se. Infectious colitis per se, where I'll try to check for occult blood. And moreover, where do you check for stool for occult blood? Most of the time you check for stool for occult blood in malignancies, no? I mean, if you're suspecting, let me say, a carcinoma rectum, or let me say if you're suspecting a carcinoma colon, that is when you would be doing this. Abhishek, it's already on the channel. Please search on this channel for ECG and electrolytes, and you will get one video on ECG and electrolytes, and there have been questions asked from that video multiple times. It's a shortcut. In case you don't have time for ECG, then that's the video for you guys. Okay. Yes, the treatment for this particular case, you see, most of the time this could be triggered by I know you are leading me into a controversy. I have reference from the current edition of 21st edition of Harrison also, which says that for all the cases of severe pseudomembranous colitis, the answer is vancomycin. Only for the mild variety of pseudomembranous colitis, and I can post a reference of this subsequently in our top educator telegram group also, it is fidaxomicin. So you can yourself check up the answer for, I know you are leading me into this that pharma people have said fidaxomicin. I don't dispute that, you see, but if in the current 21st edition of Harrison, it is fidaxomicin for mild one. Dr. Saab, it is only for mild variety. It's not for severe and the moderate variety. It is still vancomycin. So वो जो आपके जो भी sources हैं उनको थोड़ा refine करिए, and let's put up put videos on your description of ECG. Doc, it's already present. You just search the word ECG and electrolytes on this channel and you'll get it. Okay. Yep. And if it's recurrent also, even then for recurrent it is first, I mean recurrent में हम पहले fidaxomicin दे रहे हैं, but if you read the table, no, then in severe and moderate varieties it is vancomycin, and then it is written fidaxo. Only for the mild variety it is fidaxomicin initially. Okay. Stool for Shiga toxin anyways ruled out because we are not talking about any dysentery in this particular case. Yes, Rajendra, in recurrent varieties fidaxomicin would be given initially. Most of the time they don't put up words like that, no, they just say PMC management in a patient would be. So both of these antibiotics are used. and they would not be bothering you with any kind of controversies. Okay, so we sorted PMC, pseudomembranous colitis as a topic should not be messed up, and let's move on to the next one. We have this patient who presents with cough and shortness of breath for last 2 years, for which he has taken treatment, but he has no records. Like all Indian patients, they come to you without any records, and this chap says, I mean, he is not having any occupational risk factor, because anybody with cough and shortness of breath, I might think that he might be having a presentation of interstitial lung disease, especially pneumoconiosis, but thankfully, like, this question is not on pneumoconiosis per se. Bunty, we use metronidazole in private practice for management of these patients, and it always works. But Clostridium difficile can definitely misbehave. So in case you don't have good response with metronidazole, then it is oral fidaxomicin or oral vancomycin. It's not IV but oral. Oh, great, great, Sumit. That's a great thing that you are able to answer in your word rounds, and that's our objective. Okay, let's sort this out. The next one, guys, we are having a chap who's having cough and shortness of breath. I mean, very wide differential diagnosis. So the question is from respiratory system. There is no occupational risk factors, but he's talking about growth of molds in his house. I mean, fungus can grow due to leakage, no? That greenish, blackish growth that can occur in any Indian household, especially after the rainy season. And then there are emphysematous changes in the CT chest of this patient. He says, which of the following would you be doing in this patient? So let's look at A, serum precipitants against Aspergillus species. Where do you do this? You do this in ABPA, allergic bronchopulmonary aspergilloma. And this allergic bronchopulmonary aspergilloma is mainly due to exposure to a fungus. The fungus in this case, hi Krish, good evening, would be mainly with respect to a fungus that is by the name of Aspergillus fumigatus. Now all we need to work out is that the CT of this guy is giving very important information, which I am surprised you guys did not pick up. That is basilar emphysematous changes. So the chap is having emphysema, man. If somebody is having emphysema on a CT chest, then either he is a smoker, or if it is not smoker of the centroacinar variety, then you always read about panacinar emphysema. No, that is alpha-1 antitrypsin deficiency. I mean, in this particular question, he made you waste your time because of the fact that if you are thinking about A or C as an answer, then A and C, they are both investigations that are done for allergic bronchopulmonary aspergilloma, which is caused by Aspergillus fumigatus. But does it cause emphysematous changes? Absolutely not. Allergic bronchopulmonary aspergilloma does not cause basal emphysematous changes. In fact, what is the finding which is asked very frequently, even in your exams, one-liner MCQ? Patients of allergic bronchopulmonary aspergilloma would be having central bronchiectasis. And is this MCQ talking about central bronchiectasis? Absolutely not. This is talking about emphysematous changes. All you had to pick up was, when it comes to talk about emphysema, then the bottom line is either you're gonna be thinking with respect to I mean, you know, centroacinar with respect to smoker, or panacinar variety with alpha-1 antitrypsin deficiency. So that is what I'll go in for. I mean, the question says which test would help in diagnosis. Now, if I look at B, flow volume curve with a non-reversible airflow obstruction, I am already having the diagnosis of emphysema with me on the CT scan. No? If CT already is telling me that there is a emphysema present, then there is no need for going in for a flow volume curve in this particular case. So I would like to, in this particular chap, go in for a serum 1 alpha-1 antitrypsin deficiency. Finger glove appearance is mainly for bronchocele and not for bronchiectasis primarily. So the answer to this question is point number delta. Since the chap is having cough and shortness of breath, it's a big differential diagnosis. You need to look at CT report, which is already given you. I mean, once you read emphysema, thought process of yours has to be that, I mean, especially basilar one, you have to think in terms of either a smoker being, I mean, smoking being responsible, or the one with respect to alpha-1 antitrypsin deficiency. The answer to this one is option number D. Yep. I think you guys got a hang of it. And as far as flow volume curve is concerned, they did ask about flow volume curves also, which are discussed in the app, so you can go through that. Even in the recent INI, they asked about a flow volume curve. Okay, guys. Rahul, drug of choice for different seizures are already present in rapid revision, so absolutely no issues. हाँ जी, yes, medicine has to be simple and straightforward. No? Okay, let's move on to the next one. This 35-year-old lady presents with flank pain going to the groin, suprapubic pain on urinating, and on examination she has a costovertebral tenderness. So I'm waiting for the diagnosis from you guys because this is a two-step question. He says what investigation will be useful for this case, and that is what they do. Applying for a medical college, well, this is for doctors, so I cannot answer this here. Uh, The question talks about a patient who's having flank pain going to the groin, and then, if I just highlight this, the pain is like this going to the groin, and then there is a suprapubic pain in the patient also. So everything that is present here is talking about involvement of the kidney of this person. Now for this question, he says what would be the best way for diagnosis. So I am main focus would be on microbiology, especially parasitology, nucleic acid metabolism and biochemistry. है ना, जो हम biochemistry पढ़ते हैं तो we tend to get tired after fat metabolism and carbohydrate metabolism, and they ask questions after that. So please focus on the topics that I mentioned. IVP तो करते ही नहीं सर आजकल. सर IVP के साथ में तो एनाफाइलैक्सिस रिस्क होता है ना. Intravenous pylography as a investigation is a anaphylaxis risk. पहले तो diagnosis बोल दो सर. Costovertebral tenderness लिखा है ना. Costovertebral tenderness is always a feature of pyelonephritis. उसके बैक पे हाथ रखोगे ना इधर तो चिल्लाएगा सर जहाँ पे where if you put your hand on the back of the patient where the ribs are finishing and the paravertebral muscles are present and you put your hand there, the patient will howl with pain. So the diagnosis of this patient is a pyelonephritis. Why I'm saying pyelonephritis? Because of the costovertebral tenderness, and why this pyelonephritis is occurring is probably because of stones. The reason for that would be stones in a patient. The question says what investigation will be useful. For people saying CECT, for stones we go for a plain CT, no? For stones we don't go in for a contrast CT. It is a non-contrast CT abdomen which has been asked very frequently. So answer is definitely not option number B. Yep, it's a renal stone which is contributing to pyelonephritis component. The answer cannot be beta. The only thing is I wanted to rule out the fact that this would be a contrast in our CT scan. We'll go in for an ultrasound that can help us pick it up. Yep. Why not kidney stones? Because I cannot see kidney stones on clinical diagnosis. Stones are only a etiology. Clinical diagnosis of this patient is pyelonephritis. I understand investigation of choice for kidney stones is obviously a CT, but that's a plain CT, no, not a contrast CT. And why I don't want to do a contrast CT is not cause of contrast induced nephropathy. The point is contrast induced nephropathy थोड़ी ना करा दोगे यार. उसका मान लो KFT deranged है. And urine microscopy से आपको पता क्या चलेगा? वो तो UTI तो वैसे ही है ना. On urine microscopy you will be able to see pus cells in this patient. You would be able to see RBCs in this patient. That's not gonna give you any diagnosis per se. If I just zoom it in, zoom it out, the point of mine is if it comes to urine microscopy, the pus cells and the RBC, you know it from the clinical profile of the patient. The question says what's going to be useful for this patient? How do you narrow down to the diagnosis? So you can go in for an ultrasound. If it was a CT abdomen plain given in this MCQ, then the answer would have been fine. If suppose this MCQ did not mention CECT and mentioned a plain CT and there was an ultrasound versus a plain CT, no issues. But otherwise, it's gonna be a plain ultrasound in this particular case. And IVP is not done, sir. Both problem with option number B and option number D will be that you have to give a contrast. And in anybody with a kidney involvement, the issue is always gonna be with respect to possible contrast nephropathy. Investigation of choice for ureteric stone is also non-contrast CT abdomen. Yep, it's given in FMG solutions also. Sir, ultrasound is not being done to diagnose pyelonephritis in this case. Ultrasound is being done to identify the etiology behind it. Again, the bottom line that is coming up, I'm still getting B in the feed. I'll repeat that again. Why we are not going in for B in this particular case would be the issues are maybe the kidney is damaged severely, creatinine is hampered. So I am not gonna recommend. Yeah, that's okay. If you Revise in reverse direction, that always works. Answer to this question is option number A, guys, and I'd call it a silly mistake. The next one is on multiple endocrine neoplasia. The patient presents with bone pain, psychic moans, and vision abnormalities. So when you read about bone pain, psychic moans, you anyway know about the fact that this presentation is usually described with respect to a parathyroid adenoma, and whenever that's the standard presentation. Whenever PTH issues are there, parathyroid adenoma is present, PTH is elevated, it causes kidney stones, it causes bone reabsorption. So bone pain, psychic bones are definitely no. Pratish, for contrast induced nephropathy we use N-acetylcysteine. Prognosis is good with contrast induced nephropathy. Prognosis, I would say, relatives are not gonna like it, especially they're gonna be after your life that sir, you caused kidney failure in a patient which you could have prevented. But yeah, you can manage it with fluids and N-acetylcysteine. Okay. This chap is having bone pain, psychic moans. That's a presentation with parathyroid adenoma. Past medical history shows surgery for a pancreatic tumor. So two P's are coming up. One is a pituitary adenoma. Second is a parathyroid adenoma. So you very well can understand we are talking about three P's in this particular case. And whenever we read about three P's, it's gonna be multiple endocrine neoplasia that we need to consider. The third P which is present in these patients would be a pituitary adenoma. And this pituitary adenoma can be picked up with the MRI and can also explain the vision abnormalities of this patient. So if you read this question per se, a lot of people have answered C. MRI had shown a pineal calcification. So pineal calcification can be present in a normal person also. Pineal calcification could be present even in a normal person also. So would you call that is it same as a pituitary adenoma? This is multiple endocrine neoplasia, that is fine. But the answer to this question is not option number C. Read it carefully, sir. MRI head showing it should say MRI head showing a pituitary adenoma. It is saying MRI head showing a pineal calcification. So the answer is definitely not C. High anion gap metabolic acidosis is what you read with cult, conditions like ketoacidosis, lactic acidosis, toxins. So that's not the scenario in this case. Yep. Yeah, MRI is the best way to differentiate. I think that's covered in orthopedics, and I think the orthopedic solution is already released, Amit. So tubercular arthritis, avascular necrosis, we can separate. हैगमा होता है हाई एनायन गैप, रैपिड रीजन से पढ़ना. हैगमा होता है हाई एनायन गैप मेटाबॉलिक एसिडोसिस. The answer to this question is definitely, Shivam, you need to search ECG and electrolytes and you will be getting it, right? It's a separate video on ECG and electrolytes. Telegram channel is Top Educator, TOPEDUCATOR. Option A says cyanide nitroprusside test. This is primarily for cystine stones, and we are not talking about cystine but calcium stones. The correct answer for this one is option number Bombay, low urinary pH, because high calcium can damage the kidney of this person. This question was based on exclusion capabilities. You had to pick up. The trick in the question was when it's going to be option number C, MRI head. Bhavin, multiple endocrine neoplasia is asked in your FMG exam also. So you need to be aware of what is multiple endocrine neoplasia, what are the tumors. All the three P's are very simple and straightforward. And only trick in this question was that pituitary adenoma is not given in option number C. So that's the main aspect which had to be understood. So we are sorted for this question. Let's move on. YouTube rapid revision is enough for Doc, come on, medical science is too vast to answer such queries. You have to put in your best efforts, put your heart and soul, जितनी ताकत है लगा दो, दिन में 14-15 घंटे पढ़ो, है ना, सोना बंद कर दो, कुछ नहीं होगा, सोओगे नहीं ना. If you don't sleep for a few days, nothing is gonna happen. Ibiza questions are tricky even in the exam. Let's move on to the next one. Okay, this question is per se especially for FMG students here. Mutations on which of the following will lead to Ehlers-Danlos syndrome? Yes, guys, the answer is to be given only by FMG students. Yep. Let's see your quick responses. Very good, very good. I am getting answers now. Hanji, Hanji, Hanji. Hi, Dr. Ram. Thank you so much for the beautiful words that you wrote. Made up my day, pumped me up. भाई फिब्रिलिन 1 तो मार्फन सिंड्रोम का होता है यार. मार्फन सिंड्रोम इज फिब्रिलिन 1. फिब्रिलिन 2 इज अ कंडीशन जिसका नाम होता है कंजेनिटल. आई मीन दिस वुड बी डेफिनेटली अ प्रॉब्लमैटिक वन. सो फिब्रिलिन 2 जो है वो तो वेरिएंट ही है ना यार. Yes, I'm still waiting for answers. I mean, Fibrilin 2 would be a variant only related to Marfan. So, अगर 1 नहीं है तो 2 भी आंसर नहीं होगा. हाँ जी, रबरमैन सिंड्रोम है ना, तो फिर किसका डिफेक्ट है सर? सर, इट्स अ डिफेक्ट ऑफ कोलाजन. इलास्टिन का डिफेक्ट कैसे कर सकते हो? ये तो एफएमजे एग्जाम का क्वेश्चन है. इलास्टिन के डिफेक्ट से क्या डिजीज होता है? तो इलास्टिन के डिफेक्ट से जो डिजीज होता है उसका नाम होता है क्यूटिस लैक्सा. Elastin defect results in cutis laxa. It's a defect of collagen, man. That's a very simple, straightforward question that should not have gone wrong. I mean, you read this so many times in bio. Somebody was asking how to study biochemistry in front of you guys, right? Biochemistry में क्या पढ़ते हैं? We tend to read, bit of nucleic acid, bit of glycogen storage disorder, Von Geer के Pompe, थोड़ा fat metabolism पढ़ लिया, बस एनर्जी खत्म हो जाती है. और वो पूछता है ये उसके बाद में म्यूकोपॉलीसैकेराइडोसिस, कनेक्टिव टिश्यू, न्यूक्लिक एसिड मेटाबॉलिज्म वाला. I mean, this is not the kind of question that should go wrong. So I think yes, absolutely right, Dr. Ifat. You're perfectly right, and I'm getting lot of my primary source of preparation टॉप रैंक के लिए क्या हर जगह से पढ़ना होता है. तो बैटमैन ऐसा होता है कि जैसे लोग थर्ड ईयर से पढ़ना शुरू करते हैं, तो जैसे थर्ड ईयर में वो फार्मा पढ़ते हैं गर्ग सर से, है ना. फिर फाइनल ईयर में आते हैं तो मुझसे मेडिसिन पढ़ लेते हैं. फिर उन्हें लगा कि यार अब कहीं से टेस्ट देना है, तो कहते भाई सेम प्लेटफॉर्म से टेस्ट देने के दूसरी जगह से टेस्ट दे लेते, तो फिर वो कहीं पे टेस्ट दे लेते. तो अलग अलग रिसोर्सेज को यूज कर लेते. तो ऐसे नहीं होता कि दे आर गिविंग इंटरव्यू एट डिफरेंट प्लेसेस बिकॉज समबडी इज ट्राइंग टू गिव देम समथिंग. वो तो वैसे हो गया, मतलब जैसे आपको कल को कोई केमिस्ट आके वो होता है ना कि दीज फार्मास्यूटिकल कंपनीज वुड बी गिविंग इंसेंटिव टू यू गाइस, है ना. तो वो हमें वही वाली साइकोलॉजी लगती है कि भाई हम किसी को पे कर रहे हैं. ऐसे नहीं होता सर. नोबडी गेट्स पेड. इट्स जस्ट हार्ड वर्क दैट अल्टीमेटली मैटर्स. I mean, people use different sources for their preparation, and that is why they end up on different platforms. And आमिर फोर्थ ईयर में क्यों YouTube पे अपनी लाइफ में कोई enjoyable वीडियो देख लो, बिकॉज अभी आपका प्रेशर क्रिएट होने वाला है. Just joking. I mean, knowledge is always welcome. So you need to focus on the aspects here. Yep. Answer to this question is option number alpha, sir. कोलाजन डिसऑर्डर इज ऑल्सो ऑस्टियोजेनेसिस इम्परफेक्टा. लेकिन इस सवाल में जो मेन ट्रिक था वो तो यही था यार कि लोग इलास्टिन आंसर कर रहे हैं. क्यूटिस लैक्सा है वो. वेरी स्ट्रेट फॉरवर्ड वन लाइनर क्वेश्चंस. अब आई कैन गो इनटू द स्पेसिफिक डिटेल्स ऑफ दिस डिसऑर्डर व्हिच विल ईट अवे इनटू द टाइम, एंड दैट वुड नॉट बी. incentives are banned. Yep, incentives are banned, sir. Incentives are banned, but still pharmaceutical companies will find a way across to push them across. So in US it's totally banned, yes, but still it happens in United States also. Our objective is to minimize all the cut practice and all those things, but then there are some things which obviously cannot be stopped. And anyway, this is not a platform to discuss that. Okay, great. Moving on to the next one, we have the 16-year-old boy, gross abdominal distension, abdominal pain for past 24 hours, and I think everybody could pick up this finding which I have tried to show here. I have started. It's a good start. Sir, it depends on you. I mean, the kind of quality that we can give you will obviously not be present, but it's a personal decision. Yes. Max yield medicines start with fluids and electrolytes, then move on to reading about epilepsy, then read ECG and I mean 2 videos on ECG, then emergency medicine, basic life support and advanced cardiac life support. Then in endocrine, read adrenal gland. Don't read diabetes, don't read I mean, traditionally everybody starts with diabetes and thyroid. Read parathyroid and adrenal gland because they are the ones which are asked. Yes, I think everybody is very well clear regarding the presentation of this guy. The vitals of this patient are little on the higher side. The X-ray abdomen of this patient is showing a bent inner tube sign. That would be a presentation of a sigmoid volvulus. and I've already drawn the image before you, so I think this would be relatively a piece of cake for you guys, right? The bent inner tube sign or the coffee bean sign that we study. So you're very good at this from radiology. In any patient who's having this kind of an issue, any surgical patient, we are anyway going to go ahead with IV fluids. The resident on duty has already given IV fluids for this patient. We are not going to go for observation. The poor fellow, his tummy is going to be affected very badly. He's presenting with abdominal pain for 24 hours, and I tell somebody I'm going to observe you, he's definitely not going to be, he would say I would change the doctor. Yes guys, I'm still waiting for this one. Sir, it's not an upper, it's not a small bubble obstruction. This guy is having a predominant large bubble obstruction. So NG tube कैसे help करेगा sir? It's a large bubble obstruction, no. Offline start होगा sir, NEET PG and FMG के बाद में, and for FMG it would be सरमान Institute. हाँ जी चलो छोड़ो अभी, ये बताओ यार NG ट्यूब क्या है, वो लार्ज बबल में कैसे मदद करेगा? रेक्टल ट्यूब करेंगे, डी आया डाइवर्जन कोलोस्टमी, तो हम उसको बोलेंगे कि तेरा हम कोलॉन काट के इंटेस्टाइन से बाहर निकाल देंगे एंड देन यू विल पास पॉटी थ्रू योर टमी. आई मीन सर, you tell somebody this, that I'm gonna cut your colon and put it out through your tummy, the guy will go ballistic and his parents will go ballistic. Sir, colostomy कब करते हैं? Divergent colostomy when there is, let me say, like for example they are talking about a patient who's having ulcerative colitis or perforation हो गया वहाँ पे, क्योंकि there is gonna be inflammation present, so you will have to first wait for the inflammation to come down. So you go in for a divergent colostomy in those cases where immediate end-to-end anastomosis cannot be done. Sir, first of all, we need to go in for what Sanket is answering very beautifully. We need to go for sigmoidoscopy in this patient, and we need to go in for a endoscopic detorsion. And those of you who are saying rectal tube, the rectal tube is put subsequently. This rectal tube is to maintain. We are not talking about a flatus tube. We talk about a rectal tube. That is to maintain the detorsion. But first we need to do a detorsion, no? So what will do detortion? That is going to be the endoscopy in this patient. The case is a sigmoid volvulus, a must-know topic for large bubble obstruction, and they always ask about one question on interstitial obstruction is always there in any exam, whether it be a NEET PG exam or maybe a FMG exam. It could be small bubble, large bubble. वो तो वही पूछता है भाई, proximal and distal small bubble obstruction के बीच का differences. In this particular case, we will be going in for a sigmoidoscopic detorsion. The primary objective of this particular case would be that first you will have to do a sigmoidoscopy in this patient and achieve a detorsion. Once you have achieved a detorsion, then you will place a rectal tube to maintain the detortion in this patient. So जी हाँ, you are right. अगर sigmoidoscopy होता तो आंसर बिल्कुल सही हो गया होता. Flatus tube डालते हैं सर, flatus tube डालेंगे, अभी rectal tube नहीं है ना. Right, this is not a, I mean we are not going in for a flatus tube at the moment, right? Rectal tube डालने की बात हो रही है, that is subsequently to maintain detorsion. So the main treatment for anybody having a sigmoid volvulus, I mean the question says what is the intervention for this patient? I mean the question says best intervention for this patient. Best intervention for anybody having this would be to get rid of the problem, no, just by, even if I say flatus tube, ठीक है, तो flatus tube डालने से क्या patient ठीक हो जाएगा? नहीं होगा ना. आपको तो इंटरवेंशन पूछ रहा है ना वो, कि भाई क्या करोगे, तो आप बोलेंगे भाई ट्यूब डाल के डिकम्प्रेस कर देंगे. दैट वुड नॉट बी हेल्पिंग इन दिस केस. द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर बी. द कॉन्सेप्ट इज बबल ऑब्स्ट्रक्शन. भाई पढ़ लेना, अगर नहीं पढ़ा हुआ है टॉपिक तो जस्ट गो थ्रू दैट. द स्मॉल बबल लार्ज बबल ऑब्स्ट्रक्शन का अगर लोग पुराने साल के पेपर देख लो तो आपको पता चल जाएगा कि कौन से वाले क्वेश्चंस आते हैं और कौन से नहीं आते. चलो, moving to the next one. Yes, Rohan, I'll try based on my schedule to do it on a regular basis. Let's move on to the next one. Yes, brilliant guys, you are all brilliant chaps. All of you are all pumped up. क्या ढीले से बैठे हो? Relax, okay. Aggressively question solve करो यहाँ पे. ये मत सोचो कि भाई ये कौन सा इन्हीं का क्वेश्चन है, ये FMG का है. भाई उसको बोलो कैसा भी क्वेश्चन दो सर, हम सॉल्व करके देंगे. मेंटल एटीट्यूड इज कि कैसा भी है सर सॉल्व करेंगे. अग्रेशन यही होती है यार, ऐसे डरने से नहीं काम चलता कि ये कौन से वाले एग्जाम का क्वेश्चन है. सेल फोन, ओ यार कोई बात नहीं, सबको सेल फोन से एडिक्शन है आजकल, तो अपने आवर्स अब थोड़े रिड्यूस कर दो, ठीक है. मतलब रोज अगर आप बैठते हो 4 घंटे 5 घंटे, तो 4 एकदम से तो बंद होता नहीं है ना. है ना। वो वैसी बात होती है ना, जैसे हम बोलते थे अल्कोहलिक को कि पीना बंद कर दो, तो वो एकदम से नहीं होता, उसको बोलते हैं धीरे धीरे, राइट। चलो, लेट्स मूव ऑन टू द नेक्स्ट वन। टेलीग्राम क्विजेस की जगह पे सर वी आर गोना डू इट, सर वी आर गोना डू दिस, नो। सो दिस आई थिंक इज मोर इंटरेक्टिव। टेलीग्राम पे तो यू विल नॉट बी एबल टू हियर मी एंड विल नॉट बी एबल टू अंडरस्टैंड द लॉजिक ऑल्सो। We are having this lady being evaluated for stroke. The resident gave you a couple of findings. Patient is awake, alert, orientation to time, space and pace person. So thankfully there is no coma in the patient. There is no visual deficit with right-sided gaze deviation. मतलब उसकी दोनों eyes जो हैं वो जैसे कि दोनों eyes जो हैं उसकी अगर ये left है ये right है, so both the eyes of the patient are moving towards one side. Gaze deviation is there. Patient, you know, you read about that. Patient looks towards the side of lesion. Patients look away from the side of the lesion. So something like that. Most patients who are having cortical stroke now, they would be looking towards the side of the stroke. Cranial nerve examination is normal in this chap with normal reflexes, normal tongue movement. That tells you that even brainstem is not involved in this patient. The brainstem is not involved in this patient. There is no phase deviation, apathy is noted, one of the keywords, and you are noticing loss of power in the legs. If you read about leg weakness, only leg weakness, no arm weakness, no hemiplegia, only monoplegia or paraplegia, and along with that you have apathy, it tells you the fact that the patient's anterior cerebral artery is affected. The correct answer for this question is option number A. So these questions are very simple, straightforward. When it's gonna be MCA involvement, he will always give you those A's, no? Aphasia, apraxia, complex hallucinations, and he'll always talk about a contralateral arm weakness, contralateral leg weakness. So I mean you are gonna be able to identify this on the basis of those A's written in a question. And P1 PCA is midbrain stroke, so he will always talk about cranial nerve palsy, like P1 supplies the midbrain, no? So he will talk about third nerve palsy, fourth nerve palsy, fifth nerve palsy, which could be, I mean not all, but any one of these could be affected. In this question he did not say, I mean the question said there is no cranial nerve involvement in a patient. So stroke localization questions can be asked definitely. I mean this will be the word written in the question and you just need to identify. समझना सिंपल सा यही है कि भाई अगर वो उसमें फीचर ही ऐसे हैं, ए बुलिया का मतलब बोलना नहीं चाहता, बोल तो सकता है पर बोलना नहीं चाहता, बिकॉज द पर्सन विल बी एट दिस पॉइंट ऑफ टाइम वेरी अग्रेसिव, ही माइट बी यूजिंग अब्यूजिव वर्ड्स विद यू, हिज सन एंड डॉटर विल बी अपोलोजेटिक टू यू एंड दिस पर्सन इज गोना बी यूरिनेटिंग इन फ्रंट ऑफ यू, यूरिनरी इनकॉन्टिनेंस. आई मीन दोज आर वेरी स्टैंडर्ड फीचर्स दैट यू रीड विद एंटीरियर सेरेब्रल आर्टरी इन्वॉल्वमेंट. यस यस. तो अलर्ट एंड ओरिएंटेशन टू टाइम स्पेस पर्सन, वो तो यार हायर मेंटल फंक्शंस के लिए ना. That orientation to time space and person is for higher mental functions. Okay. Cortical stroke, na eye deviation is cortical stroke Ganpat. That eye deviation is explained by cortical stroke ना. In every time आप सुनना, stroke का 2 घंटे का वीडियो है, थोड़ा ज़्यादा है, but सुनोगे तो उसमें समझ में आएगा कि अगर cortical stroke होता ना, तो cortical stroke में हमेशा क्या होता है कि person looks towards the lesion. Brainstem stroke में he looks away from the lesion. रोहन, हाँ जी रोहन, you are right. स्मॉल वेसल स्ट्रोक करते हैं सर, करते हैं. अभी आगे क्वेश्चन, अभी आज टुडे इज माय जॉब टू टॉक अबाउट दीज एस्पेक्ट्स है, तो करेंगे आगे. स्मॉल वेसल स्ट्रोक भी आएगा, लैक्यूनर स्ट्रोक पे भी फोकस करेंगे. दैट्स अ प्योर मोटर स्ट्रोक बेसिकली, प्योर मोटर या प्योर सेंसरी. अब मैं उस पर बोलूंगा तो फिर लोग जो हैं डिसोसिएट हो जाएंगे इस चीज से, डिस्कशन से, क्योंकि वी आर ट्राइंग टू कीप इट सिंपल रूटीन थिंग्स दैट वी कैन रिवाइज है. चलो अगले पे आते हैं. अब ये वाला जो क्वेश्चन है, दिस इज स्पेसिफिकली फॉर दोज ऑफ यू हु आर प्रिपेयरिंग फॉर FMG एग्जाम. एंड बहुत सिंपल सा सवाल पूछ रहा हूँ, तो बाकी लोग थोड़ा साइलेंट हो जाएं. आप आंसर करना चाहते हो तो कर सकते हो. यस थैंक्स सर. नॉम व्लॉग्स, श्योर, वुड लव टू मीट यू. स्पाइना बाइफिडा ओकल्टा प्रेजेंट्स एज व्हिच ऑफ द फॉलोइंग. ओकल्टा है ना, मतलब मदर को तो पता नहीं है, पेशेंट को भी पता नहीं है, तो कैसे पता चलेगा. मेडिकल हचिंसन पढ़ते हैं सर, क्लिनिकल एग्जाम के लिए हम पढ़ते हैं. या तो एक आती है पीजे मेहता, और पीजे मेहता नहीं पढ़नी तो फिर हचिंसन से पढ़ लेना, या मैक्लोइड्स भी आती है. हाँ जी, हाँ जी. ओके, आई एम गेटिंग A and B as आंसर. ओकल्टा मतलब मनिंगोसील एंड माइलो मनिंगोसील तो दिखाई देगा ना सर, ये दोनों जो होते हैं ये तो दिखाई देते हैं. इसको तो स्पाइना बाइफिडा मैनिफेस्टा बोलते हैं. मनिंगोसील एंड माइलो मनिंगोसील जो है, हाँ जी, गोल वाला पढ़ लो सर, एक किताब कोई से भी पढ़ लो, खत्म करो उसको पढ़ के. ऑप्शन नंबर ए एंड बी को ओकल्टा थोड़ी ना बोलेंगे, दे विल बी विजिबल ना. इफ समथिंग इज विजिबल टू द नेकेड आई, इफ यू आर हैविंग अ स्वेलिंग ऑन द बैक ऑफ द चाइल्ड जिसमें ट्रांस इल्यूमिनेशन टेस्ट पॉजिटिव है, इट्स अ सैक कंटेनिंग स्पाइनल कॉर्ड, सैक कंटेनिंग मेनिंजेस, अगर वो विजिबल है तो उसे ओकल्टा थोड़ी ना बोलते हैं. स्पाइना बाइफिडा ओकल्टा क्या होता है, ओकल्टा में क्या प्रेजेंट होगा, वो एक पीछे आ भी तो रहा था, है ना, सेकरल डिंपल पे हेयर प्रेजेंट होते हैं. तो पीछे एक बच्चे की फोटो आ रही थी ना कि हनुमान का री, they would be hair present. सेक्रल डिंपल, इधर एट द सेक्रल डिंपल पे क्लेफ्ट प्रेजेंट होगा यहाँ पे. ओकल्टा, ओकल्टा मतलब ओकल्टा तो मदर के लिए है ना यार, या फिर ओकल्टा इज गोना बी फॉर द पेशेंट. आपको एज अ डॉक्टर कैसे पता चलेगा कि ओकल्टा है, देयर इज टफ्ट ऑफ हेयर. आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर सी. सर ये गलत नहीं होना चाहिए था. इफ यू मेस्ड इट अप देन इसको पढ़ लो न्यूरल ट्यूब डिफेक्ट को. जो सबसे सिवियर न्यूरल ट्यूब डिफेक्ट होता है दैट वुड बी अ कॉम्बिनेशन ऑफ एनेंसेफेली एंड माइलोमेनिंगोसी. ये सबसे सिवियर न्यूरल ट्यूब डिफेक्ट होता है. द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर सी, lumbar sacral hypertrichosis, that is tuft of hair at the sacral dimple in the patient. Parastasis जो है वो सबसे सिवियर वाला डिफेक्ट होता है. न्यूरल ट्यूब डिफेक्ट तो आना चाहिए सर. चलो क्वेश्चन पूछ रहा हूँ आप लोगों से, विच इज द कॉमनेस्ट न्यूरल ट्यूब डिफेक्ट इन इन्फेंट और डायबिटिक मदर. ऑप्शंस है स्पाइना बाइफिडा और सेक्रल एजेनेसिस. फटाफट से कमेंट बॉक्स में मेंशन कर दो. Yes, guys. Commonest neural tube defect in an infant or diabetic mother. Waiting for your answers there. स्पाइना बाइफिडा के लिए ए बोल देना, सेक्रल एजेनेसिस के लिए बी बोल देना. हाँ जी. क्या कर रहे हो यार, क्या कर रहे हो. सेक्रल एजेनेसिस आंसर नहीं है. क्या कर रहे हो यार. आई I मीन mean, ये तो एफएमजे एग्जाम का ब्रेड एंड बटर क्वेश्चन है. मोस्ट करेक्टरिस्टिक न्यूरल ट्यूब डिफेक्ट इन इन्फेंट और डायबिटिक मदर इज सेक्रल एजेनेसिस. दो अलग अलग क्वेश्चंस हैं. द मोस्ट कॉमन वन इज स्टिल स्पाइना बाइफिडा ओकल्टा. सर जी पढ़ो, केयरफुली पढ़ो. द कॉमनेस्ट वन इज स्टिल स्पाइना बाइफिडा ओकल्टा. सेक्रल एजेनेसिस तो करेक्टरिस्टिक होता है, मोस्ट स्पेसिफिक होता है. एब्सोल्युटली सौम्या, शी सेड दैट राइट. करेक्टरिस्टिक इज सेक्रल एजेनेसिस. अब यार ये तो बिल्कुल बच्चों वाली चीजें हैं, मतलब अभी बच्चों वाली चीजें थोड़ी ना डिस्कस करेंगे यहाँ पर. द मोस्ट स्पेसिफिक वन इज sacral agenesis. Commonest one is spina bifida occulta. These are very simple straightforward facts. पढ़ लेना सर न्यूरल ट्यूब डिफेक्ट को अगर गलत हुआ तो. ओके जी, वी आर मूविंग टुवर्ड्स द एंड ऑफ आवर डिस्कशन. तो थोड़े मैंने क्वेश्चन मिक्स्ड बैग रखे हैं, मतलब थोड़े वो लॉन्गिश क्लिनिकल वाले. एग्जाम में भी ऐसे होगा दैट देयर वुड बी सम लॉन्गिश क्लिनिकल वंस और उसके बाद में इजी वाले होंगे. आइलेट और लैंगरहैंस दे प्रोड्यूस इंसुलिन. वो सबसे ज्यादा कहाँ पे होते हैं. यस गाइस. ट्रीटमेंट नहीं होता रोहन, प्रिवेंशन होता है. न्यूरल ट्यूब डिफेक्ट ट्रीट नहीं हो सकता. हाउ डायूरेटिक्स कॉज इंक्रीज इन यूरिक एसिड. डिहाइड्रेशन. किसी को अगर डायूरेटिक देंगे ना, तो अगर कोई ज्यादा डायू जैसे थाइजाइड ज्यादा लेता है, तो थाइजाइड्स की वजह से क्या होता है कि बॉडी से पानी निकल जाता है ना, तो यूरिक एसिड की क्रिस्टलाइजेशन हो जाती है. देयर इज डिहाइड्रेशन व्हिच कंट्रीब्यूट्स टू दैट. हाँ जी, हाँ जी. मैक्सिमम बीटा सेल्स ऑफ पैंक्रियाज वुड बी प्रेजेंट विद रिस्पेक्ट टू. हाँ जी, द टेल ऑफ द पैंक्रियाज. द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर डी. अब इसमें तो कोई लॉजिक नहीं है, ये तो सिंपल फैक्ट है कि भाई हाईएस्ट कॉन्सेंट्रेशन यहाँ टेल पे होती है. तो पैंक्रेटाइटिस अगर टेल में हो रहा है तो आई मीन सब्सिक्वेंटली पेशेंट को क्रॉनिक पैंक्रेटाइटिस होगा और डायबिटीज मेलाइटस होने के चांसेस ज्यादा हो जाते हैं. You know, if a person has involvement of the tail of pancreas, then from a doctor's perspective, why are you studying this is, if it's going to be with respect to pancreatitis acute हुआ, then it becomes chronic pancreatitis. Then chronic pancreatitis would cause reduction of the pancreatic mass. So when you read the triad ना, triad of chronic pancreatitis जिसमें स्टेटोरिया होता है, diabetes mellitus होती है, the diabetes mellitus occurs because of that the major chunk of beta cell mass can be lost. The correct answer for the question on the screen for islet or Langerhans would be the tail of pancreas. Yep guys, the answer is not A, it is option number D. Moving to the next one, you are checking out dorsalis pedis artery. This is a patient who's a big time smoker. बर्जस डिजीज का पेशेंट है. आप उसकी डॉर्सेलिस पेडिस आर्टरी जो है कौन से बोन के अगेंस्ट पैल्पेट करोगे? Concordance sort of basically means that you see normally what happens is ST elevation and I would say like this, that ST and T always go in same direction. Like if T goes up then ST also goes up. But in bundle branch block now you will see ulta, main vector के उल्टा जा रहा होगा. तो if you listen to me in bundle branch block I use the word concordance there, discordant or non-concordant word, that this rule is not being followed. Whatever is the main QRS vector, जैसे QRS vector positive है तो ST भी ऊपर जाता है, T भी ऊपर जाता है. तो अगर if this rule is not followed, right, the main vector is let me say positive और ST depression हो रहा है. और another way to understand is only ECG जिसमें ST elevation ST depression एक साथ होता है. नॉर्मली या तो ST elevation होगा और या ST depression होगा. ओनली ECG जहाँ पे ST elevation और ST depression आपको V1 से V6 में चेंज मिल जाएगा. स्पेक्ट्रम आ रहा है, कहीं पे ST elevation कहीं पे ST depression, तो बंडल ब्रांच ब्लॉक में होता है. हाँ जी, यू वुड बी palpating this against the navicular bone. ये पहले भी मैंने क्वेश्चन कराया था. आई थिंक दिस इज अ रिपीट वन दैट आई मेंशनड हियर. एंड मीडियल मेल्यूलस भी आंसर आ रहा है. नहीं सर, मीडियल मेल्यूलस तो नहीं होगा. Dorsalis pedis artery is on the upper part of the foot, no? So you would be pressing it against the navicular bone. And this is a question that we have discussed earlier. Okay, ji. Moving to the next one, you have this young male presenting with swelling in the left testis. And on palpation, it feels like a bag of worms. So I think everybody understands that the question is related to a varicocele. And I'm waiting for your answers here. What condition should be ruled out? Yes, guys. This can be taken as a representation of the two kidneys. This is the renal vein. Okay, let me just sketch it better. And I'm still waiting for your answers. I'll just zoom it a little out so that the question is in focus, using a finer pen in this case. This is inferior vena cava. These are the two branches. This would be the renal vein. This would be the kidney. This is the scrotum of the patient. Yes, yes. We must rule out whenever it's on the left side. No? Whenever a person is having left-sided varicocele, we must rule out presence of left-sided renal cell cancer, because what happens is that this drains into the left testis. I think I've discussed this earlier. The right one will go into the inferior vena cava. So if you look at the representation here, if somebody will be having a hypernephroma or a renal cell carcinoma and it can press on this testicular vein, then it's going to cause a left-sided varicocele. The answer to this question would be option number D. The primary reason for this would be that you can understand this from this diagrammatic representation that I made before you. The concept is that the left testicular vein drains into the renal vein. Yes, renal mass compressing the gonadal vein. And yes, YouTube sessions are free. Okay guys, let's have a look at your anatomical issues. COVID-19 patient is coughing in the ward. Which of the following structures would be used to increase the flow rate in coughing? Which of these would be causing the narrowing of the trachea? Because when you cough, no, there's an increased velocity. I mean, when you cough, there's an increased velocity of air exiting out, and that helps you clear your secretions. So which muscle? Yes, CP Singh, thank you so much for all the love. Okay. COVID-19 patient is coughing in the ward and he says which of the following, which of these muscles present here would be responsible for narrowing of the trachea? Okay, cricothyroid will narrow the trachea. Is cricothyroid a muscle that increases air velocity in coughing? Does cricothyroid play a role in coughing? No, sir. The answer is not cricothyroid. The answer is not cricothyroid, sir. Still getting B as a feed, sir. Cricothyroid muscle जो है वो कफिंग में कब से रोल प्ले करने लग गया? कफिंग में या तो डायफ्राम होता है या फिर एक ऐसा मसल होता है जो कि ट्रेकिया के अंदर होता है. पढ़ना इसको एनाटॉमी से. द आंसर टू दिस क्वेश्चन इज ए ट्रेकियालिस, है ना. इसके बारे में पढ़ते भी नहीं है. मेजॉरिटी ऑफ पीपल ने पढ़ा भी नहीं है नाम, है ना. The basic concept is trachealis is a muscle, sir, which is present. We have this incomplete. ये तो पढ़ते हो ना आपकी, there are C-shaped cartilaginous rings. तो उनकी back side पे there would be trachealis muscle. What this will do is it will narrow the lumen of the trachea. So that narrowing of the lumen of the trachea will cause that explosive force to be created, and that explosive force to be created will help in coughing of this patient. यार वो बीवर साइन वाला क्वेश्चन मिस हो गया रोहन, आप मेरे को ना मेल पे भेज देना marvamedicine@gmail.com। अभी मुझे इसको वाइंड ऑफ करना है यार, अदरवाइज दीज गाइज विल से कि सर इतना लंबा सेशन हो गया। ठीक है, तो आप मेरे को marvamedicine@gmail पे भेज दो, मैं बीवर साइन करा दूंगा आपका सॉल्व। Everybody hates anatomy, there is no solution for this, right? Everybody hates anatomy, it's just the fact that we have to get used to it, sir। hating something से क्या होता है कि नेगेटिव वाइब्स आ जाते हैं। वो जो वर्ड है ना, आप उसको मत लिखो, आपने कमेंट को डिलीट कर दो। वो इसलिए सजेस्ट क्यों कर रहा हूँ, मतलब दैट्स ओनली अ सजेशन फ्रॉम माय साइड। ऑल ऑफ यू ग्रोन पीपल, व्हेन यू से दैट वर्ड नो, दैट रीइंफोर्सेस इन योर ब्रेन। तो उससे क्या होता है कि फिर आदमी को ना मतलब नेगेटिव वाइब्स क्रिएट होते हैं, फिर आपने उसको नहीं कर सकते। तो वहां पे आप क्या करो, आप करो यार कि जो भी है, मतलब एटीट्यूड ये रखो कि जो भी है भाई पेपर निकालना है ना, इट्स ऑल अबाउट पॉजिटिव एटीट्यूड। तो आप उसके साथ में सॉल्व कर सकते हो। द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर ए। आ जाते हैं जी अगले क्वेश्चन पे। 13 इज द करंट वन यार, बाकी भी हैं, प्लेलिस्ट है सर। यू गो टू द चैनल ना, देयर इज अ प्लेलिस्ट, तो प्लेलिस्ट में शुरू 8 जो हैं दे आर ऑफ लास्ट ईयर, दे आर प्रेजेंट। आप उसको लूप पे लगा के सुनते रहो, सो यू विल कम अक्रॉस लॉट ऑफ थिंग्स जो कि आपको लगता है आती हैं पर नहीं आती होती हैं, तो दैट वुड हेल्प यू। फार्मा हो जाएगा सर, हो जाएगा सर जी, रिवीजन क्लास ही चल रही है। चलो, विटामिन B6 जो है वो पायरिडॉक्सिल फॉस्फेट का, मतलब पायरिडॉक्सिन है ना, तो ये पायरिडॉक्सिल फॉस्फेट का कोएंजाइम होता है। और पायरिडॉक्सिल फॉस्फेट जो है, PLP जो है, दैट प्लेज अ इंपॉर्टेंट रोल इन मेटाबॉलिज्म ऑफ लिवोडोपा। द करेक्ट आंसर फॉर दिस क्वेश्चन इज ऑप्शन नंबर ए। जिन पे प्लेन लिवोडोपा चल रही होती है उनको हम विटामिन B6 खाने से मना करते हैं। यस यस। नहीं, इतना एक्सट्रीम भी मत करो यार, इतना एक्सट्रीम भी मत करो। गर्लफ्रेंड मत बनाओ। विटामिन B6 फ्रेंड बना लो, फ्रेंड जोन कर दो। Vitamin B6 is gonna be a coenzyme with respect to pyridoxal phosphate which affects the metabolism of levodopa. So जिन लोगों को plain levodopa चल रही होती है, if somebody is taking levodopa, carbidopa, no issues, but if it's plain levodopa, then vitamin B6 उसका metabolism जो है वो affect कर देता है। So हाँ जी, मेरा अगला सेशन है ना, वो अगला वाला सेशन मैं करा दूंगा आपको। मैं सर एक ही पढ़ा रहा हूँ, जो अभी है दैट वुड बी मल्टीपल। तो चलो जी, आज के लिए ये लास्ट क्वेश्चन होगा, नहीं सेकंड लास्ट क्वेश्चन है। हाँ जी, हाँ जी। A 35-year-old lady presents with what she calls a stomach pain. Yes guys, let's focus, let's focus। चलो, let's not get personal। 35-year-old guy 35-year-old lady presents with what she calls a stomach pain। meningitis सुमंत कराया हुआ है यार। common organisms, no, it is E. coli and Klebsiella for pediatrics in India, group B streptococcus for newborn babies, children is again streptococcus, adults is also streptococcus। strep pneumonia is the common answer for adults and children। बच्चों में streptococcus एक लगती है। yes guys, you have to comment on the answer, it's your turn। आपके reflexes मुझे चेकआउट करने हैं फटाफट से। 35-year-old lady presents with what she calls a stomach pain। most patient ये बोलते हैं पेट में दर्द को, वो इंग्लिश में बोलेंगे सर स्टमक पेन हो रहा है। on examination tenderness is noted in the right lower quadrant of the patient। this is the problem, this patient has come to you, right lower quadrant में pain है। patient is sexually active and is using birth control pills। workup shows a elevated TLC। हाँ जी, हाँ जी, मोर देन सफिशिएंट है, मोर देन सफिशिएंट है। या सादिक, गुड टू हियर फ्रॉम यू। एसटीडी क्लिनिक। यार राइट अपर क्वाड्रेंट पेन के साथ कोई पेशेंट आएगा तो अपेंडिसाइटिस नहीं सोचोगे क्या? अपेंडिसाइटिस में पेन कहां से स्टार्ट होता है? पेन स्टार्ट्स यूजुअली फ्रॉम द अम्बिलिकस, जिसको पेशेंट स्टमक पेन बोल रहा है। अपेंडिसाइटिस, ये जो क्वेश्चन है सर, दिस क्वेश्चन इज बेस्ड ऑन मर्फीज ट्रायड। कि भाई मर्फीज ट्रायड में क्या पढ़ते हो, पेशेंट क्या बोलता है कि भाई मेरे पेट में दर्द हो रहा है, उसको बोलो हाथ रख के बताओ, तो इंडियन पेशेंट विल डू लाइक दिस, नो स्टमक पेन हो रहा है, दे विल पुट देयर हैंड ऑन द टमी, प्लस एलिवेटेड टीएलसी इज आल्सो प्रेजेंट। और भी ज्यादा फीचर मिल रहा है कि भाई ये तो प्रोबेबली कुछ कॉज हो सकता है। तो क्या करोगे, अल्ट्रासाउंड एब्डोमेन करोगे। अगर बी था, अगर बी था तो आप ये सोचो कि यूरिन प्रेगनेंसी, समबडी इज ऑन ओसीपी, पेट में दर्द है, और आप उसे कह रहे हो कि तू यूरिन प्रेगनेंसी टेस्ट करा, तो आपने यहाँ पे क्या सोचा होगा, आपको ये लगा होगा कि इसको रप्चर्ड एक्टोपिक प्रेगनेंसी हो सकता है ना। अगर आप यूरिन प्रेगनेंसी टेस्ट कर रहे हो तब भी तो अल्ट्रासाउंड करोगे। अगर सपोज मैं बोल रहा हूँ, सपोज वर्स्ट के सिनेरियो में आपको ये लगा कि ओसीपी का फेलियर हो गया, even if you say it is OCP failure, then she would have conceived, and if she would have conceived, even then you will do ultrasound, no? Pelvic examination would be done primarily with respect to the fact कि pelvic examination तब करते हैं जब आप STD सोच रहे हो। Option number A and D is when you are thinking that she is having salpingitis. तो क्वेश्चन में ये तो लिखा नहीं है कि मल्टीपल पार्टनर्स आर प्रेजेंट इन द पेशेंट, एंड सपोज इवन इफ द पर्सन इज नॉट यूजिंग प्रोटेक्शन, राइट, एनीबडी विद राइट लोअर क्वाड्रेंट पेन, फर्स्ट फॉरमोस्ट आपको अपेंडिसाइटिस सोचना है। फर्स्ट डिफरेंशियल डायग्नोसिस ऑफ दिस पेशेंट इज अपेंडिसाइटिस, देन यू हैव टू थिंक इन टर्म्स ऑफ साल्पिंजाइटिस, और फिर उससे पूछोगे उसके पीरियड्स की हिस्ट्री, बिकॉज अगर एमेनोरिया प्रेजेंट है, if in this MCQ it was mentioned amenorrhea for XYZ weeks, then you will think in terms of a ruptured ectopic pregnancy. Standard question, sir, which they give you जो routine casualty में case आता है, they are the ones that they would be giving you in the exam. I mean, right lower quadrant pain, the standard thing is appendicitis, salpingitis and ectopic pregnancy in the patient. तो आप STD में चले गए, कई लोग confuse नहीं होना है, right? Keep the focus on and keep on solving these questions and you would be on your way. वो एक एक लाइन रटने से कुछ नहीं होता ना, वो कहते हैं ना भाई हम चांटिंग कर रहे हैं, ये करो, उससे नहीं होता ना। मतलब चांटिंग इज इंपॉर्टेंट, ऐसा नहीं, मैं ये नहीं क्रिटिसाइज नहीं कर रहा हूँ, चांटिंग ठीक है एक लिमिट तक है ना, बट देन दैट डजंट सॉल्व एमसीक्यूज ना। Curve 64. Okay, Jeff Bezos, next time I'm gonna do it. Last question for today and we are winding up. Cranial nerve most commonly involved. सॉरी अभी सर्जरी के ही चल रहे थे, तो आप यही तो सर्जरी वाले कितने सारे क्वेश्चन डिस्कस किए, अपेंडिसाइटिस डिस्कस किया। चलो अगले सवाल पे आते हैं। विच cranial nerve is commonly affected in diabetes mellitus? Yes guys, एवरीथिंग इज यूजफुल यार, एवरीथिंग इज यूजफुल, ऐसा नहीं है, आई एम नॉट सेइंग कि ये मत करो वो मत करो, करो बट एक लिमिट पे जाके तो फिर क्वेश्चन तो सॉल्विंग करनी है ना यार, अल्टीमेटली तो वही मैटर करता है। नहीं मैं ऐसा कुछ नहीं कह रहा, नथिंग लाइक, आई डोंट हैव एनीथिंग अगेंस्ट एनीबॉडी, इट्स जस्ट दैट आप करो, इट्स ऑलवेज गुड, बट देन द पॉइंट इज दैट यू हैव टू डू मल्टीपल थिंग्स इन योर करियर। चलो जी, वेरी गुड। कॉमनेस्ट नर्व इन्वॉल्वड इन डायबिटीज मेलिटस वुड बी, दैट इज द cranial nerve number 3 that is involved, it is oculomotor nerve palsy with pupillary sparing, हमेशा लिखा होता है third nerve palsy with pupillary sparing. So great guys, it was a nice interaction with you guys, and I think I have given you a mixed bag today. A lot of questions were very simple and straightforward and some of them were obviously a bit twisted, so इसके साथ में ही you have to keep on doing as many things as possible. एंड अगर आप ये जो क्वेश्चंस मैंने आपको बताए इनकी एक बार दोबारा से सुन लेते हो, प्रैक्टिस कर लेते हो, तो यू वुड डू ग्रेट। सो थैंक्स गाइस फॉर योर टाइम, पेशेंस लास्ट 5 days में। कीप ऑन डूइंग एज मेनी एमसीक्यूज एज पॉसिबल फ्रॉम कस्टम मॉड्यूल, स्पेशली ट्राई टू डू इट क्वेश्चंस विद रिस्पेक्ट टू आई वुड से द वीकर टॉपिक्स। चलो वी विल बी डूइंग सेशन सब्सिक्वेंटली ऑल्सो। गॉड ब्लेस यू। इसी टाइम पे होगा सर। Yes, take care. Bye bye. God bless you.